Good afternoon, friends. We are starting with prenatal screening and diagnosis of aneuploidy, which is chapter 2 of Marrow Fetal Medicine Notes. We are revising this introduction part. Prenatal screening is done to rule out Down syndromes, Edwards syndrome, Patau syndrome, other aneuploidies, predict the risk of preterm preeclampsia and IUD also. There are some scientists name mentioned here which have contributed historically. First one is Sir G.J. Mandel, who discovered the laws of inheritance for monogenic disorders. Monogenic disorders means single gene is involved and it is not associated with aneuploidies. These are chromosomal disorders. These are not genetic monogenic disorders. Next is Sir John Hilton Edwards, who described Edwards syndrome and demonstrated obvious abnormalities on ultrasound in Edwards syndrome. Then coming to next scientist, that is Sir Langdon Downs, who described trisomy 21 or Down syndrome. In trisomy 21, there is no obvious early abnormalities on USG. Now, Down syndrome. Screening of Down syndrome, there are certain features which are associated with Down syndrome. Intellectual disability is seen in 95% or more than this. Congenital heart disease in 30 to 40%. GIT atrasias in 20%. Hypotonia, learning disabilities, Alzheimer's disease, leukemias, and there is 15 to 20 times higher risk of leukemias in these babies. So an extra pair of an extra chromosome is present, 21 chromosome, 2 chromosome from maternal side and one from paternal side. But here there is duplication of the chromosome and there are 21 chromosome, 21 chromosome. This is trisomy 21. 50% of fetuses with Down syndrome are viable. So 50% fetuses are viable. Out of these viable fetuses, 60% are structurally normal. Ultrasound alone cannot pick up all Down syndrome cases with accuracy, and the incidence of Downs is 1 in 600. Life expectancy for people with Down syndrome has been increased dramatically over years, that is 25 years in 1983 to 60 years today. There are two modes of prevention for Down syndrome. First one is primary prevention and secondary prevention. Primary prevention, we can avoid late pregnancies, that is after 35 years. Pre-implantation diagnosis or PIGD, which detects presence of Down syndrome at pre-implantation stage, and there we can decide for termination. Secondary prevention includes screening, that is CVS or chorionic villi sampling and amniocentesis if screening is positive in first trimester or second trimester, and if positive and if screening with CVS and amnio is also positive, then we can offer termination. And this is an informed choice. So first we have to tell the patient that they are screen positive, we do CVS and amnio, and then we decide for termination. Risk of Down syndrome with age. So age is most important factor associated with Down syndrome. And whose age? Maternal age. More prevalent among mothers of older age, exponential rise in prevalence beyond 35 years of age. Advanced maternal age is the strongest epidemiological link, 0.6 to 41 per thousand between 15 to 45. Now there are genotype surprise seen in this case. So this is the etiology. 95% of trisomy 21 are due to gametocyte accidents that is non-disjunction, which is not able to predict. Hence, universal testing is offered irrespective of age. 1% mosaic Down syndrome and 4 to 5% are associated with translocations. Now, there is one study in AIMS pediatric cohort where 842 cases were taken, and out of these 842 cases, 67% occurred in women with less than 35 years of age, and this had occurred due to early completion of family in our Indian culture before 35. Most of the females get married before 35 years of age and plan pregnancy early. So, this is a bias. This is a age-based bias. So, more cases are seen more cases are seen in this population at less than 35 years of age. Now, the ideal testing scenario. Definitive diagnosis to all pregnant women given by karyotyping. invasive technique. This is an invasive technique since fetal tissue is required and it carries a risk of miscarriage. It is very expensive. More practical approach is required based on personalized risk of aneuploidy. Now, the concept of what is the concept of screening in these females? Filtering out most of the normal and filtering in most of the abnormals. So filtering in we can do by taking the maternal age, maternal serum biochemical markers, certain fetal ultrasound markers also known as biophysical markers. So what is a marker? Marker is anything which is found more frequently in fetuses suspected to have a particular condition, like an absent nasal bone, which is most likely to be associated with Down syndrome. There is one a priori risk. A priori risk is when every woman has some risk that her fetus may be affected by chromosomal defect, and through this a priori risk, we calculate a priori probability, where we use the maternal age, higher age, more incidence, gestational age, higher gestational age, lesser incidence. Why it happens? Because if any aneuploidy or abnormality is fetus is present, then usually these fetuses abort or die at early gestational age. So if gestational age is more, then this fetus has escaped that risky situation of miscarriage. So higher gestational age is associated with lesser risk, and maternal demography like maternal age, maternal BMI, and maternal race is also a significant factor. MOM is multiples of meridian, where we calculate the patient's risk and the median result at that gestational age. Likelihood ratio or LR of a given marker is the incidence of a marker in trisomy 21 pregnancies divided by incidence in chromosomally normal pregnancies. Positive LR means positive likelihood ratio. This is the number of times the presence of a marker increases the likelihood of disease. So if likelihood ratio is more than 1, then it is associated with the presence of the disease. Likelihood ratio of less than 1 is associated with the absence of disease, and if it is 1, then it is of no practical or little practical significance. Then there are two terminologies also. First one is SPR. SPR is screen positive rate and FPR is false positive rate. Screen positive rate and false positive rate are almost identical if done in large sample. 97% of screen positive females are false positive. So only 3% are true positives, rest are false positive. Now there are some demographic parameters associated with Down syndrome. First one is maternal weight. So if maternal weight is higher, then serum marker values will be lower in heavier women. So this may act as a bias. Then race of the patient, Afro-Caribbean race. HCG AFP levels are more in Afro-Caribbean race. HCG is also 10% higher. PAPE is more than 60% higher. IVF pregnancies are associated with dating abnormalities, HCG injections. So HCG is higher in such IVF pregnancies, and unconjugated estriol levels and PAPE are lower. Type 1 diabetes mellitus is also associated with higher levels of AFP. Unconjugated estriol levels are low in such females, and previous history of Down syndrome is also associated with higher risk. Smoking is associated with increased levels of inhibin by 60%, and PAPE and beta HCG are reduced by 20% almost. So how do we screen in such population? So this is the screening design. A priori, first of all, we will calculate the a priori risk or a priori probability. Then if there is higher risk, then we offer them screening and calculate the absolutes, convert it into multiples of meridian, and calculate the likelihood ratio. So after calculating this a priori probability and likelihood ratio, we multiply both and calculate post-test probability. For multiple markers, a priori risk and composite LR is equal to patient-specific risk for Down syndrome. Now there are certain screening models offered in such females with risk of Down syndrome. Age-based screening, more the age, more the chance. Anti-based screening, nuchal thickness is increased, higher risk of Down syndrome. Then there are certain first trimester tests, that is anti-based screening. We have already studied about these. Double test, combined test, additional USG markers like like nasal bone, tricuspid regurgitation, ductus venosus, and this is the time which is best for screening, and we can through combined test and additional markers we can predict around 95% of cases with detection rate of 95% with these markers. Second trimester test includes triple test, that includes beta HCG, AFP, and unconjugated estriol, and if we add inhibin, it gives rise to quadruple test. And then there is genetic sonogram or level 2 or TIFA scan. Third trimester includes integrated test, sequential screening, and contingent screening. Now there is relative efficacy. What is relative efficacy? When we fix the FPR, FPR is false positivity rate, and compare the detection rate. Fixing FPR and comparing detection rate is more effective than fixing detection rate and comparing FPR. So we try to fix the false positivity rate and then compare the detection rate. Now coming to first trimester screening. If only maternal age is taken, then the detection rate is 30%. If double markers like maternal age and serum biochemical markers, which includes PAPA and beta HCG, the detection rate rises to 50%. And if this is combined with NT, then detection rate rises to 85% further. Combined and additional markers give a result of around 92 to 95%. So what are the markers that we use in first trimester? It includes HCG and PAPA, which are the products of the placenta. Timing is 11 to 13 weeks, 6 days of gestation, where CRL is around 45 to 84 mm. Ideal time is 12 to 13 weeks. Risk cutoff in first trimester screening is 1 in 250 pregnancies. Coming to second trimester screening, screening includes triple test or quadruple test. In triple test, we take AFP, estriol and conjugated estriol levels, HCG. And if we take these three parameters, then detection rate is 65%. If we add inhibin as the fourth marker for quadruple test, then detection rate is increased to 65%. This HCG and inhibin are the placental products. Ethinyl estradiol secreted by fetal liver is adrenal product and fetal adrenal product, and AFP is also secreted by fetus through fetal liver. So two products are through fetus and two products are through placenta. Now second trimester screening is done at 15 to 21 weeks of gestation, where we see BPD. BPD is biparietal diameter and it comes out to be 31 to 52 mm. Here we have seen CRL of 45 to 84 mm is needed, and here 45 to 84 mm, and here 31 to 52 mm of BPD is taken. So ideal timeline for doing second trimester screening is 16 to 8 weeks, and the risk cutoff is similar, that is 1 in 250. So in second trimester screening, we see the fetal, because fetus is abnormal, so fetal products are reduced, and placenta in turn increases its products. So fetal products are reduced, that is AFP and ethinyl estradiol levels are low, and fetal placental products are increased, that is HCG and inhibin are increased in Down syndrome. So where we see H for high. So H is high, means HCG and inhibin are high. Only placental products are decreased in which, so this question can be asked, which placental product is decreased in Down syndrome. So PAPA is reduced in Down syndrome. There are certain trisomies, which are trisomy 18 or Edwards syndrome, where beta HCG is high and PAPA is reduced. And in trisomy 21, beta HCG and PAPA both are, this is wrong. Here beta HCG is high and PAPA is low, and here trisomy 18, free beta HCG is low and PAPA is also. So both are low, then this is trisomy 18, and if free beta HCG is high but PAPA is reduced, it is trisomy 21, and if all are high, then this is neural tube defect. Now coming to genetic sonogram, also known as level 2 scan or anomaly scan. This is TIFA. TIFA is targeted imaging for fetal anomalies. The detection rate is 56% and the false positivity rate is 3%. So in this scan, we see every system in detail and comment on that. So you can see cardiac echogenic foci, ventriculomegaly, increased nuchal fold, bowel, we are seeing echogenic bowel, kidneys we are seeing mild hydronephrosis, short femur, short humerus, ARSA, absent or hypoplastic nasal bone. Now coming to third trimester screening. In third trimester, we do integrated screening, sequential screening and contingent screening. So what is integrated screening? Integrated screening is we try to integrate something. Means we do first trimester screening through combined test but did not reveal the result to the patient. And then in second trimester also, we are doing one test, that is quadruple test at second trimester. After this, both reports are in our hand, and after these reports we give a detection rate of around 93%. So this gives a detection rate of around 93%. Disadvantage is failure to return for the second blood test. Suppose you did first trimester screening but patient did not return for the second blood test, so you did not reveal first trimester result also. So this is the disadvantage. Now coming to contingent screening. Contingent screening is test result is given after combined test. So you do first trimester screening test, you reveal the result. There are three possibilities. Either there is high chance of getting aneuploidy, high, then low, and there is intermediate situation also. So in high, we do a direct test. What is a direct test? Direct test is either a CVS or a amnio. In low testing, in low results, none is required. And if intermediate result, so here H for direct test, intermediate for quadruple test. Quadruple test is done in second trimester. And if screen is positive in this test with an intermediate result, then we do direct test in such situations. And and if again intermediate result has come, then there is no direct test is required. Both intermediate, no direct test is required. And if both low, no testing is required. And if both high, then you do CVS or amnio. Then there is another testing known as sequential testing, where we do two-stage screening and risk is given at each stage. If screen negative group, screen positive and screen negative. Screen is positive, then higher test is advised, and if screen negative, then offered the second test. Post risk of the first test becomes a priori risk of the second, and the detection rate is 90%. So here we are revealing the result of the first test, and then we are offering second test in screen negative patients. So this we have revised previously also. Then first trimester screening allows early diagnosis testing by CVS is possible. There is optimum timing for NIPT or non-invasive prenatal testing, and there is also option for termination. Now, what is the ideal timing for first trimester screening? Biochemical markers are done before 11 weeks. Anatomical markers means USG parameters are seen after 14 weeks. So if we do a scan in between these two timelines, then it is the best time to screen for first trimester aneuploidy screening, 12 to 13 weeks of gestation. What would be the place for screening? Accredited lab with software, quality control on a daily basis, and a regular audit. Now coming to screening in multiple pregnancy. So in multiple pregnancy, two fetuses are there. Maybe one fetus is affected, one fetus is normal. So this can create confusion in the results. So first trimester screening, here we can use anti-nuchal translucency and serum markers can be used, but the performance of serum markers is poor. So first of all, establish chorionicity. If monochorionic twins are there, then identical risk is given to each fetus, and if dichorionic twins are there, then we separately calculate aneuploidy risk for each fetus. In second trimester, S for S. In second trimester, we only do serum markers, which are less accurate than in singleton pregnancy. And if triplets or higher orders are there, then this can cause confusion, means these serum markers and NT can cause confusion. So we directly go for ultrasound markers. Always combined test is done, which is followed by NIPT or non-invasive prenatal testing. NIPT is never done as first line, except, so there are three situations where we do NIPT as a first line. The first one is maternal age more than 38 years, USG finding indicating a increased risk of aneuploidy, and history of prior pregnancy with the trisomy. So if maternal age is more, if USG is suggestive, or if there is history. So in these three situations, NIPT is done as a first line. Now screening in IVF pregnancy. For screening in IVF pregnancy, we can take dating, and because HCG injections are given, so HCG levels are also high, so a screening test should be done within 5 days, should not be done within 5 days of the injection. And if donor eggs are taken, the donor age determines the a priori risk, not the surrogate age. Test interpretation is 1 in 250, high risk. Then if this is there in 1 in 250 pregnancy with high risk, counseling is done and invasive testing is offered. If low risk, then regular antenatal follow up. And if the risk is between 1 in 250 to 1 in 1000, then counseling and non invasive testing is done. So thank you for listening.